Hello everyone, this is the Dr. Madhusudan Rao and the program I teach medical students. Today in our lesson I am going to touch briefly on sickle cell disease, its definition, pathophysiology and brief account of clinical presentation. Yes, look at this picture. This child is suffering from sickle cell disease. This is a slide that is peripheral smear of the patient with sickle cell disease. You can see the sickle-shaped blood RBC target cells and poikilocytosis. This is a child in a pathetic situation with sickle cell disease. Sickle cell disease is a genetic disorder of autosomal recessive inheritance due to point mutation in the beta globin gene, leading to the formation of qualitative abnormality of hemoglobin, resulting in chronic hemolytic anemia with inflammatory hypertrophic obstructive vasculopathy, hypercoagulopathy, and ischemic injury to organ systems. This is the comprehensive definition that I have designed for you students. This is genetic disorder of autosomal recessive inheritance. There should be 2 copies of the mutant genes in homozygous state that manifests. There is a qualitative abnormality of the hemoglobin. Unlike in thalassemias, where there is a quantitative defect in the hemoglobin, here the hemoglobin is structurally abnormal. Okay. Structural abnormality is due to the mutation in the gene controlling the synthesis of beta globin, wherein there is abnormality of the base pair. That is, as a result, the valine replaces the glutamine, the amino acids at the 6th position of the beta globin chain. Let us talk briefly about the pathophysiology. This is one of these hemoglobinopathies due to qualitatively abnormal hemoglobin, that is sickle hemoglobin, designated as HbS. Genetically transmitted with autosomal recessive inheritance, there is point mutation in the beta globin gene. Okay. What is the change in the beta globin gene? There is change in base pair, thymine replacing adenine at 6th codon. Okay, of the HbS gene. So this results in the valine, the amino acid, replacing glutamine at the 6th position of the beta globin molecule. Essentially, beta globin is a protein molecule which has got the amino acids. Amino acid valine replaces the glutamine at 6th position. Okay, this could exist in a homozygous state, heterozygous state, or hemizygous state. Homozygous state is represented by HbSS. That means both the alleles are abnormal, resulting in both the beta globin chains are abnormal. That is SS. Heterozygosity is represented by HbA and S. Hemizygosity is that one with double mutations. Okay, one globin chain, beta globin chain, has got the mutation with HbS, other chain with the HbC. Okay, or it could be HB sickle with thalassemic gene. So homozygosity is the result of mutation in both the beta gene alleles. Okay. Well, sickle anemia is homozygous state with more than 90% of the sickle hemoglobin, whereas sickle disease comprises of sickle cell anemia, okay, HBSC and HBS thalassemias. Okay, there is a double mutation, HBSC and SBS thalassemia, and homozygous state is both the alleles are abnormal. So sickle cell anemia comprises of all the three. It could be a combination of sickle cell anemia, HBSC or HBS thal. So when you think about a sickle cell disease, it could be any of these three. Whereas when you talk about sickle cell anemia, it is purely homozygous state of the sickle cell. This is the difference between sickle cell anemia and sickle cell disease. In sickle cell disease, the sickle hemoglobin could be more than 50%. The rest is the HBSC or HBS thalassemia. Well, sickle hemoglobin molecules in the RBC, okay, when there is a mutation and the hemoglobin is of sickle type, these RBC, they interact with each other because of cytoadhesiveness and result in the polymerization in the deoxygenate state. Okay. These polymers of the sickle hemoglobin gives rise to some changes in the RBC. What are those changes? The RBC becomes sickle shaped, it becomes more rigid, okay, and becomes difficult to pass through the microcirculation. That results in the obstruction to the microcirculation, okay, causing mechanical obstruction to the microcirculation, ischemic injury to the tissues, and premature lysis of the RBC. Okay. There is increased adherence of the RBC with sickle hemoglobin. They adhere to the RBC, to the vascular endothelium, to other cellular components in the circulating blood. There is increased adherence of these cells to the vascular endothelium and also other cellular components of the blood. Okay. Well, the injury to the endothelium, secondary to the hypoxia, trigger inflammatory response. Okay. And that results in the formation of microthrombi. There is the depletion of the nitric oxide as a result of oxidative stress. Because nitric oxide is the natural vasodilator, it results in the further vasoconstriction in the microcirculation, causing greater impedance for this flow of blood through the microcirculation. So impedance to the circulation, injury to endothelium, triggering the hypercoagulable state, forming the microthrombi, further perpetuates the vascular endothelium and hyperplasia, ultimately resulting in the hypertrophic obstructive vasculopathy. That results in the ischemic injury to the end organs. Okay. There is associated disturbance in the iron metabolism because of the continuous hemolysis, releasing more and more amount of iron. That adds to the increasing load of iron perpetuated by the regular blood transfusions. Because these RBC are abnormal in shape, they are trapped in the microcirculation and undergoes early lysis, resulting in chronic hemolytic anemia. This disease is characterized by certain crises. It could be aplastic crisis, it could be hemolytic crisis, it could be like sequestration crisis, etc., which you are going to touch in the clinical manifestations. So as such, this is the disease of chronic hemolysis with chronic hypertrophic obstructive vasculopathy, with a state of hypercoagulopathy and chronic inflammation, resulting in ischemic injury to the organ systems. Okay. This is the comprehensive definition of sickle cell anemia. This is the peripheral smear of normal individual and that with that of the sickle cell anemia. This is the abnormal sickle cells and target cells, etc. Coming to the clinical manifestations. We try to touch these clinical manifestations in the chronological order. So number 1, fever and bacteremia. A child diagnosed of sickle cell anemia, if he presents with fever, it indicates it is a medical emergency because the patient suffers from immunodeficiency because of functional asplenia, which can set in as early as 4 to 6 months of life. Functional asplenia. So there is capsular bacteria resulting in sepsis is the most risk in these particular patients with sickle cell anemia. So this should be treated with higher antibiotics like ceftriaxone, after taking the blood samples for culture. Okay, if culture shows salmonella, you should suspect presence of osteomyelitis, which you have got to search for that and treat effectively. Then other problem is aplastic crisis. Aplastic crisis is a result of the parvovirus B19 infection. Caused by associated with temporary suppression of red cells. There is erythropoiesis is suppressed, resulting in profound anemia. There could be associated fever and reticulocytopenia. Anemia with reticulocytopenia is suggestive of aplastic crisis. Okay, this can be associated with sometimes with chest pain, sequestration crisis, glomerulonephritis, or stroke. That means parvovirus B infection can be associated with sequestration crisis or acute chest syndrome. This should be treated with blood transfusion to get the hemoglobin level normal and stabilize the hemodynamic status. Splenic sequestration. This is the life-threatening situation. It's a complication that occurs in early childhood between 6 months to 2 years of age. There will be rapidly enlarging spleen with left abdominal pain, left hypochondrial pain. It will result in profound anemia with falling hemoglobin to the extent of less than 3 grams per cent. Here there is profound anemia with reticulocytosis and thrombocytopenia, unlike in aplastic crisis. Okay, in aplastic crisis there is anemia with reticulocytopenia, whereas in this clinical situation there is anemia with reticulocytosis and thrombocytopenia. And patient may progress to hypovolemic shock if not treated early. The cause is not known. Sometimes it is triggered by fever caused by bacterial or viral infections. You have got to treat the patient with IV fluids and blood transfusion. The blood transfusion should be targeted to get the hemodynamic status to normal, not to get the hemoglobin level to normal. This point has to be remembered because sequestrated blood returns back into the circulation that result in overloading the system with excessive blood volume. So you have to target the blood transfusion to correct the hemodynamic status, not to get the hemoglobin to normalcy. So there could be recurrence. Recurrence, if it all occurs, it occurs within 6 months following the preceding sequestration. If recurrence occurs, so the child must be advised for prophylactic splenectomy. Then coming to the next presentation could be sickle cell pain. This is the characteristic feature of sickle cell disease. It could occur in infancy as dactylitis, hand-foot syndrome, or it could be acute vaso-occlusive pain. Okay. Dactylitis or hand-foot syndrome, it is the first manifestation of pain of sickle cell disease. Occurs in 50% of the infants and children under 2 years of age. It could be symmetrical or unilateral pain. You will see the swelling and pain of the hand and feet that are treated with pain relievers. Acute vaso-occlusive pain. This is a feature of sickle cell disease. It is unremitting pain with abrupt onset. Okay, occurs mostly in chest, abdomen, or extremities. Okay, this is precipitated by prolonged swimming and exposure to cold. That's why we always advise the patients not to get exposed to cold, not to take the cold water bath. Okay. Sometimes physical stress, infection, dehydration, or acidosis may precipitate this particular vaso-occlusive pain. This is the result of tissue ischemia due to obstruction to microcirculation. So sometimes needs hospitalization when the child does not improve at home by covering with warm blankets, massage, or warm medication. If he does not respond to this plan of treatment, hospitalization and IV opioids, IV fluids when there is dehydration should be the plan of treatment. Avascular necrosis. It commonly affects hip. It is a cause of acute or chronic pain. The patient will be suffering recurrent pain in the hip joint. Sometimes he will limp. There could be shortening of the limb if it occurs recurrently with joint damage. The risk factor being HBSS with alpha thalassemia, frequent vaso-occlusive crisis, and elevated hematocrit. These are the risk factors to develop avascular necrosis of hip joint. So during follow-up, we have to monitor whether he is going to have the increasing hematocrit. Okay, that has to be corrected. The pain is treated by opioids for acute pain, followed by physical therapy. Priapism. It occurs at the mean age of 15 years. It could be stuttering or continuous. Sometimes it is prolonged, lasting more than 24 hours. This is the result of sluggish blood flow in the corpora cavernosa. The most common time of occurrence of pain is between 3 a.m. to 6 a.m. The cause is not known. Treated by hot showers, pain medication, and aspiration of blood from the corpora cavernosa followed by adrenaline irrigation at hospital, followed by urological consultation. Then sickle hepatopathy and sickle cell intrahepatic cholestasis. These are the hepatic consequences of sickle cell disease. Sickle hepatopathy is reversible. Okay, associated with fever, right hypochondriac pain, presence of jaundice, mild rise of alkaline phosphatase. It resolves spontaneously. Whereas sickle cell intrahepatic cholestasis is irreversible presents with jaundice, coagulopathy, hepatocellular failure, and it requires liver transplantation. Neurological manifestations occurs little later. They may present as overt stroke or silent stroke. Overt stroke is observed by around 18 years of age in 20% of the patients. There may be ischemic strokes resulting in neurological deficit lasting for more than 24 hours. This is the criteria. With or without positive MRI. This is called overt stroke. That is, neurological deficit lasting more than 24 hours with or without MRI findings. Silent stroke is MRI findings without neurological deficit. Okay. So it should be monitored by transcranial Doppler, and there should be recurrent blood transfusions in order to maintain and bring down the sickle hemoglobin level less than 30% in order to avoid overt stroke. Coming to the pulmonary manifestations. These are the second most common cause of hospitalization and mortality. Okay. Commonly involves left lower lobe. They are triggered by the infection caused by streptopneumonia, mycoplasma, or chlamydia. Fat embolism from bone marrow infarcts is also a contributory factor for pulmonary manifestations, resulting in acute chest syndrome. Okay, it is diagnosed as acute chest syndrome if any of the two following are present, that is, fever, respiratory distress, cough, hypoxia, and chest pain. Okay, if there is pneumonia with any of these two, that is associated with fever, respiratory distress, or cough, it can be defined as acute chest syndrome. These patients are treated with oxygen therapy, spirometry, antibiotics, monitoring SpO2, sometimes blood transfusion, and pain medication. It is not advisable to give the blood transfusion in all the patients except if there is decreasing SpO2 saturation, increasing distress with or without X-ray findings, and falling hemoglobin. These are the criteria to go for blood transfusion. If there is increasing distress with a decreasing oxygen saturation and falling hemoglobin levels, these things to be considered before you go for blood transfusion. Renal manifestations of sickle cell disease are rather late manifestations, but they have to be monitored regularly. The patient should be monitored for hematuria, microalbuminuria, presence of hypertension, and renal insufficiency in view of the serum creatinine, blood urea nitrogen, etc. And urinary concentration defects and nocturnal enuresis. The patient should be assessed for cognitive abnormalities, presence of retinopathy, presence of delayed puberty, and presence of leg ulcers. These are all the clinical manifestations that have to be monitored in a patient with sickle cell disease. Oh, my dear students, thank you for patient listening. We'll meet you again in the next class, in which we are going to talk about the diagnosis and management of the child with sickle cell disease. Thank you once again. We'll meet again in the next class. Until that time, bye-bye.